Program today is therapeutic updates, best practices, and the role of effective prescribing in the treatment of attention deficit hyperactivity disorder in children. And I'm Dr. Floyd Arcellee. First of all, we're going to describe the challenges associated with the diagnosis of ADHD, then apply existing diagnostic recommendations and criteria to an outline of the practice and management of ADHD treatment, to identify treatment modalities currently available for the management of ADHD and apply them to patient cases utilizing evidence-based medicine, to evaluate a treatment plan for a specific patient based on case studies, and to optimize safety and efficacy in those cases, suggesting modifications for improvement of treatment outcomes. And finally, to describe the challenges associated with treating patients with ADHD. Let's get started with a discussion of epidemiology. Population prevalence of ADHD is approximately 5% of children and 2.5% in adults. While cultural variations and attitudes influence the identification and referral of children whose behaviors are perhaps outside of the norm, these are estimates of prevalence, and estimates of prevalence in children of ADHD has been as high as 8 to 10% of school-age populations. Presumably lower in some populations such as African Americans and Latinos because of attitudes about ADHD and abnormal or aberrant behaviors. Males have greater likelihood of having ADHD than females, a 2-to-1 ratio in children, and almost a 1.6-to-1 ratio in adults. Risk factors for ADHD, of course, include genetics. ADHD is a highly heritable disorder. You're likely to find a first-degree biologic relative with ADHD or ADHD symptoms in almost every patient that you would evaluate in the pediatric realm. ADHD, we know, has many risk genes. Some have been identified with neurotransmitter systems that we associate with the treatments for ADHD, but none of these genes, and there have been identified more than 30 or 40 now, none of them has substantial risk associated with it that it would be necessary or sufficient to promulgate a diagnosis of ADHD. So each of these risk genes confer only a small amount of risk and none a substantial amount of risk for the development of ADHD. Also important are environmental factors such as low birth weight, smoking and pregnancy, neurotoxin exposure, particularly heavy metals, infection, and alcohol exposure in utero. Psychosocial factors, the family, the environment, the school, can modulate the impairment associated with the course of ADHD. This is a summary and title slide reflecting our ongoing discussion of the diagnostic challenges associated with the practice and management of ADHD. We're going to discuss DSM-5 subtypes, and there are 3. ADHD predominantly inattentive presentation, ADHD predominantly hyperactive impulsive presentation, and ADHD combined presentation. We're going to discuss the diagnostic criteria as per DSM-5 for the diagnosis of ADHD. Overall, this is a disorder of age-inappropriate behavior, so the clinician must gauge behavior and symptoms of the patient relative to his or her developmental age. To make a diagnosis of ADHD under DSM-5, you need to establish a total of 6 or more symptoms in one of 2 categories, either inattention or the hyperactivity impulsivity category. Now, DSM-5 makes the number of symptoms in either category less, specifically 5, if the patient is an adolescent or adult. Symptoms must persist for greater than or equal to 6 months, once again similar to DSM-4, and the behavior is maladaptive or inconsistent with the developmental level. Symptoms must be present before age 12 years. Now, this is different than DSM-4, where the cutoff was prior to age 7. And symptoms must occur in 2 or more settings. clear evidence that symptoms interfere or